Good day, everyone. I'm Dr. John Ward, Director of the Coalition for Global Hepatitis Elimination at the Task Force for Global Health here in the United States. It's my pleasure to welcome you to a latest edition of our webinar series where we examine different aspects of our services and progress toward hepatitis elimination. Today, we'll be looking at the new guidelines that were put out from WHO last year, recommending different strategies and therapeutics and diagnostic approaches to expand access to hepatitis B care and treatment around the world. And we have an excellent program, as I'll be showing you here in a moment. Next slide, please. As was mentioned in the title slide, we do want to thank Abbott Laboratories for their support of this edition of our webinar series. So welcome you all. We will have time for questions and comments in the chat, submitting questions in the Q&A function, and then have a discussion where we'll be seeking to get those questions and comments in front of the panelists and presenters today. This webinar is being recorded. It's on our YouTube channel. They'll be joining over 60 webinars that we have produced over the years on a variety of topics. I encourage you all to go to globalhep.org to see this edition of our webinar series, as well as the other ones that we have produced over the years. And you can sign up for our newsletter so that you can receive information about our activities overall, including future editions in this webinar series. There will be simultaneous interpretation is available, French to English, and vice versa. So that's so you can access the interpretation icon at the bottom of your Zoom screen as needed. Thank you. As I've already mentioned, this information is available up on our website. On our website, there will be a summary of this webinar, so that people can immediately see what were the highlights coming from it. There will also be the slide presentations will be available there, and then, as I mentioned, video recordings of the whole edition of the webinar series will be available on our YouTube channel, in addition to the individual recordings for each speaker and the panel discussion. So please take advantage of those resources. Today, as I mentioned, we'll be looking at the latest WHO recommendations for hepatitis B care and treatment. I'll provide some introductory remarks about that policy statement. We'll delve into that in greater detail by Dr. Wendy Spearman, who was one of the co-chairs of the advisory committee that assisted WHO in the formulation of those guidelines, in addition to her perspective as a care provider in South Africa. That will be followed by Dr. Maria Buti from Barcelona. That will be, again, looking at these recommendations and how they can be applied in her country as an upper income setting. And then we'll have a panel discussion with Dr. Anjit Bhadoria from India, Dr. Calvin, who will be talking about how these recommendations might be applied or might need to be adjusted in a country like India. Similarly, Dr. Kalpan will be discussing his perspectives on ways to modify existing guidelines for the United States, keep with the WHO recommendations, as a starting point. And then Dr. Amoko Adua from Ghana, again, with her perspectives about hepatitis B care in Africa. And then we'll have time for questions and other comments. We will also be joined by Dr. Neil Gupta from our group here at the Coalition, who will be giving his perspectives on research gaps that that are needed, and some of which were revealed in the WHO recommendation document that we're seeking to answer here at the coalition in collaboration with partners in Africa and Asia in particular. Next slide, please. Next slide. So why is this important? Hepatitis B is a major cause of morbidity and mortality around the world. This is recent data from the Global Burden of Disease study that I found quite interesting when looking at causes of disability-adjusted life years lost from primary liver cancer among young people. Hepatitis B is far and away the leading cause of this morbidity and mortality related to liver cancer, around the world, far outpacing, other causes. That can change with access to current treatments that are available that can reduce with one pill a day that are safe, very affordable, and can reduce the risk of liver cancer by 40 to 50%. However, very, very few people are diagnosed with hepatitis B, about 10% estimated globally, and only about 2% of people receiving these therapies, based on previous, recommendations. So that's the environment that we are seeking to change to make these treatments that we have now more readily available as we look forward to improved therapies that are currently in development. Next slide. To start off with, screening is important. And I just wanted to make note that WHO has previously developed recommendations for hepatitis B screening that were released in 2017, pointing out different strategies that could either be lab-based or point-of-care based for HB surface antigen testing to detect people who are infected with a hepatitis B virus, and then that being followed by nucleic acid testing that could help you make treatment decisions and monitor response to treatment. Next slide, please. And so the guidelines that were prepared by WHO were released in March of last year, and these are the links to those, and I encourage you all to go through those documents. They're very comprehensive in laying out the evidence base and the rigor of looking at the evidence that formed the guidelines that we'll be talking about today. Next slide. Again, as it relates to testing, there was a recommendation to follow a positive surface antigen test by a measure of viral load that can either be done within the laboratory or various point-of-care DNA assays strategies, and then that to be followed by reflex. There was an encouragement to have a reflex approach whereby the same specimen was used for both surface antigen and nucleic acid testing. And then the recommendations went further to encourage reflex delta testing for persons that were infected with hepatitis B. Next slide. So this is sort of the summary that we'll be going into in more detail in the coming presentations. But basically, the recommendations from WHO presented different options from which to determine eligibility and benefit of treatment for persons that were HBsAg positive, based on their with evidence of fibrosis, based on serologic testing for APRI score determination, transient elastography to look for evidence of fibrosis, or a clinical diagnosis of severe fibrosis or cirrhosis. Alternatively, one could use HBV DNA testing alone and determine to identify persons that had a viral load greater than 2,000, coupled with evidence of liver inflammation, as shown here. There was also a recommendation, or you could look at presence of co-infections, various comorbidities such as adult onset diabetes, steatotic liver disease, immunosuppression, or extrahepatic manifestations of HBV infection, or in the absence of access to HBV DNA assays, just rely on abnormal ALT levels alone for someone who was HBsAg positive. So we'll explore these in a bit more detail coming up. Next slide, please. I think the other interesting aspect of the recommendations is really focusing on testing and antiviral therapies for pregnant women that are HBsAg positive. Over and above the current recommendation for antiviral prophylaxis for pregnant women with a viral load greater than 200,000 international units, there was also a conditional recommendation of placing all HBsAg positive women on antiviral prophylaxis. So we'll again be exploring that here in a moment. Next slide. And then lastly, now that we in particular have a therapeutic option for Delta infection, increases the value of testing for Delta. And there was a recommendation, as I mentioned earlier, for reflex testing for persons that were HBsAg positive to proceed with Delta testing to identify co-infection with HDV. Next slide. Now, the real benefit here is that this is going to expand the eligibility of the persons that are HBsAg positive for HBV treatment from 19 to 25% based on a meta-analysis looking at the impact of the previous recommendations to at least a 50% of persons being deemed eligible that are HBsAg positive with these new guidelines. So the guidelines have expanded the number of persons that are now eligible to be treated for hepatitis B. And secondly, next slide, please. The other element that we'll be getting into is that there, in addition to expanding treatment eligibility, the guidelines are seeking to simplify treatment by using these different channels and then recommending ways of integrating hepatitis B into other care services, simplifying the guidelines so that they're more easily understood by non-liver specialists, and recommending different strategies to apply these guidelines throughout health systems. And so that's what we'll be exploring also in our coming presentations. Next slide, please. So it's my pleasure to welcome my longtime colleague, Dr. Wendy Spearman, who's head of the Division of Hepatology in the Department of Medicine, Faculty of Health Sciences, University of Cape Town in South Africa, to explore these guidelines in more detail and what they mean for her own practice setting. Wendy.
Thanks, John and team, for really asking me to give impact of these guidelines on the low-income countries, which really is quite close to my heart. Let's just get that up. Okay. Can you see the slides now?
Yeah. Yes.
Okay. So I'm going to really give you some insights into the impact of these guidelines in low and middle income countries. So despite diagnostics, preventative vaccines, and effective antiviral therapy, as we know, hepatitis B remains this major public health problem. And in 2022, it was estimated about 254 million people were living with hepatitis B, and it accounted for 1.1 million deaths. But as we've heard, only 13% have been diagnosed and less than 3% treated. So globally, we're off track to meet these 2020-30 hepatitis B elimination targets, particularly in low middle income countries, which account for the highest burden of chronic hepatitis B worldwide. And so if we look in Africa, 65 million, in Southeast Asia, 61 million, and in the Western Pacific, 97 million are estimated to be living with hepatitis B. And unfortunately, more than 2/3 of cirrhosis and liver cancer cases related to chronic hepatitis B are observed in these regions. And even more concerning is that most of this global burden of chronic hepatitis B can be attributed to mother-to-child transmission at the time of or shortly after birth, and this leads to high rates of chronicity. And so if we look about those low and middle income countries, we've seen the different regions, the Africa, Southeast Asia, Western Pacific. But if we look at the number of countries, they really are falling within the WHO Africa region. And that's really very concerning if we think about how we're going to address implementation of these guidelines. So in terms of diagnosis and treatment, Africa region, it's estimated there's about 4.2% coverage with only 0.2% treatment coverage. In Southeast Asia, about 2.8% diagnosis and 0.1% treatment coverage. Doing slightly better in Eastern Mediterranean area, which is 14.7% diagnosis and 2% coverage. And Western Pacific has made quite recent strides in actually improving diagnosis up to 25%, with treatment coverage of 6%. But as you can see, falling well short of those 2030 elimination targets. So scaling up testing and treatment towards the 2030 elimination goals will really require a radical simplification of diagnostic approaches, treatment criteria, and service delivery models that needs to address integration if we're going to overcome the barriers in access to hepatitis B testing and treatment. So one of the big barriers is really the cost and availability of diagnostics and this real problem of out-of-pocket expenditure. And so we look here within Africa and the Western Pacific in terms of hepatitis B testing. There's a large proportion which is out of pocket. And then even more concerningly is this wide discrepancy in the cost of the hepatitis B DNA assays. This is data from the TRIA initiative in low middle income countries. And you can see it's as low as $9 in Rwanda, but Indonesia ranges between $28 and $62. And so we need to overcome these discrepancies in actually costing of what is really an essential monitoring tool for hepatitis B. So in terms of the international guidelines, including the WHO 2015, all these guidelines really incorporate hepatitis B DNA and ALT levels into treatment decisions. And they provide a guidance on biopsy or the assessment of fibrosis and recommended treatment indications that varied according to the chronic hepatitis B status and considered other factors such as age, family history of cirrhosis, or liver cancer. And they all agree in terms of the goals of therapy to improve quality of life, survival by preventing progression of disease to cirrhosis, end-stage liver disease, liver cancer, and death. But I think we need to realize the guidelines need to be relevant and implementable in the different regions of the world. And so these updated guidelines, as we've seen from John, now provide 4 options for meeting treatment eligibility that will capture at least 50% of all surface antigen positive individuals compared to the previous 8 to 15%. So we now have the new APRI criteria for staging liver fibrosis. Importantly, we have alternative viral regimens that now are promoted. This enables potential access through HIV programs. So if you have access to monotherapy with tenofovir and lamivudine or tenofovir and tracidabine, this can actually now be used to treat. And so the limited access in some countries to tenofovir monotherapy should no longer be problematic. Tenofovir and entecavir still remain those first-line regimens. And then very importantly, this access to antiviral prophylaxis for surface antigen pregnant women. Importantly, if you lack access, as we've heard, to DNA quantification, in fact, if you're merely surface antigen positive, you should be offered tenofovir prophylaxis. The use of point-of-care surface antigen rapid diagnostic tests and hepatitis B DNA levels needs to take this testing down to primary and community care level, and the reflex hepatitis D co-infection testing, which I think we'll see might be difficult to implement in some regions. And so we look at these 4 recommendations of who to treat. It's all adults and adolescents over the age of 12, and this includes pregnant women and girls. And I think very importantly is not what one really didn't want to miss was those who had significant fibrosis based on an APRI score or liver fibrosis or cirrhosis. And you could treat regardless of what that DNA or ALT level was. And then importantly, in the absence of a DNA assay, if you had abnormal ALT levels on 2 occasions only, and you were surface antigen positive, you could initiate treatment. And I think what I'm going to go into a little bit more detail, you see there's actually one cutoff for the DNA of greater than 2000. And the ALT really is just, is it above the upper limit of normal to help you make the decision to treat? So this is really a public health approach aimed at national program managers from low middle income countries and their frontline clinicians. And these are often non-specialists, so it's not an individualized approach. The members of the development group really represented the 6 WHO regions and importantly 15 were working in low middle income countries, so had insights to the barriers and challenges that we face in implementing complex guidelines. And the aim, as we've heard, was to increase the number of people living with hepatitis B who were diagnosed, linked to, but importantly, also retained in care. So if we look at simplification of care, we need simplified treatment algorithms. So understanding that complex natural history of chronic hepatitis B, with which hepatologists love, they love those different 4 phases. And this is associated with specific virological profiles and different clinical prognosis. But this really was a barrier to initiation of antiviral therapy. It required repeated tests of measurement of the viral load, transaminase, assessment of fibrosis to predict the risk of liver-related complications and provide appropriate monitoring and antiviral therapy indications. And the level of monitoring, particularly the viral load and liver stiffness measured using transelastography, was seldom accessible in routine clinical practice in low-income countries and was mainly out of pocket, as we've seen. So we've seen that modeling studies have really shown that the treatment coverage needs to be increased to up to 80% amongst people eligible for treatment to meet those 2030 elimination targets. But as we've seen, according to the current International Liver Society treatment guidelines and the previous 2015 WHO guidelines, this only less than 20% of people living with hepatitis B were eligible for treatment. And so what we hope is that these new guidelines will have a positive impact on countries that represent 2/3 of that global disease burden, as seen in this table. So looking at diagnosis and monitoring, depending on the clinical setting and the availability of resources, you can diagnose significant fibrosis and cirrhosis based on the APRI score, which really just requires access to ALT and platelets, and you can initiate therapy. The recommended point-of-care surface antigen rapid diagnostic tests are aimed to actually improve diagnosis at primary care level, but also prevent the loss to follow-up. In terms of the hepatitis B DNA testing, the Gene Expert DNA point-of-care tests have excellent diagnostic accuracy. And we need to remember there are almost 7,000 CEPHET expert platforms across Africa, mainly used for TB and HIV, but there's extremely good awareness how to use these platforms, and we need to actually increase our use of this, particularly for hepatitis B. Viral load, as we've seen, is no longer a barrier to initiation. If you're surface antigen positive and elevated ALT on 2 occasions, that is an indication to start treatment. And what about the lowering of the DNA cutoffs? A single cutoff has been chosen at 2,000. This is going to be much easier to implement. A systematic review of 69 studies, mainly from Asia, showed what we know is this dose-response relationship between baseline HBV DNA levels and incidence rates of liver cancer, cirrhosis, and liver-related deaths. And the number needed to treat to prevent 1 case of HCC, you can see, decreases as the DNA level rises above 2,000, so between 2,000 and 20,000, 59 cases, and more than 20,000, 14. And then importantly, the number needed to treat to prevent 1 case of cirrhosis, once again, rises above 2,000, between 2,000 and 20,000, 21 cases, and greater than 20,000, 7 cases. And I think what's really going to also help the implementation is the use of a single elevated ALT if the DNA is greater than 2,000, or if you have no DNA access, an elevated ALT on 2 occasions. Treating advanced fibrosis and cirrhosis, irrespective of the DNA or ALT levels, this is important. Hepatitis B remains a leading cause of cirrhotic deaths in low middle income countries. And these simplified criteria enable easy implementation of accessible diagnostic tools. This avoidance of the gray and indeterminate zones associated with different ranges of ALT, previously between 1 or 1.5 times normal, more than 2 times normal, and there's different DNA ranges. Avoidance of these actually will enable the much easier implementation, particularly at primary care level. Lowering of the threshold, the APRI cutoff of 0.9 for significant fibrosis and 1 for cirrhosis, is very relevant for Africa. The previous WHO recommended APRI of more than 2 for cirrhosis. Studies from Ethiopia showed that this missed 50% of individuals eligible for treatment according to the EASL criteria, and 52% of those who filled the WHO criteria already had decompensated cirrhosis. So this new APRI threshold aligns with the HepSNet systematic review and individual patient data meta-analysis, which looked at nearly 3,500 chronic hepatitis B patients from Africa and recognized that an APRI score of 0.65 was a threshold for cirrhosis. And then this important prevention of mother to child. This is a key intervention to accelerate hepatitis B, particularly in low middle income countries. The recommendations that highly viremic women, if they're E antigen positive or have a DNA level of greater than 2,000, remains. But this really has been a major barrier to actually implementing mother-to-child prevention strategies, this access to e-antigen serology and DNA measurement. And so now, as we've heard repeatedly, you can treat if you have no access to the hepatitis B DNA or e-antigen serology. But importantly, this should not take the place of the birth dose vaccine, and we need to improve this. At the moment, there's only 18% of countries within Africa have a timely hepatitis B birth dose vaccine. And pregnant women must be referred for ongoing assessment for the need for long-term tenofovir. And the guidelines also recommend this as an opportunity to screen partners and siblings and children for surface antigen, and thereby vaccinate, treat, and break cycles of infection. And then this vexing issue of the reflex hepatitis D co-infection testing, depending on resources, it's obviously advised that all surface antigen positive individuals are screened. But in reality, I think we're going to be looking in low-income countries at individuals at increased risk of co-infection, particularly in countries such as Mongolia, Moldova, and countries within Western and Central Africa. But what are the implications? I think the cost of the serological or molecular diagnostics will remain a barrier, and particularly the cost and availability of the treatment bulevirtide. And I think this will be very difficult to implement within Africa. So in summary, the new guidelines are a public health approach to the management of hepatitis B, aimed at expanding criteria for the initiation of treatment and promoting implementation in low and middle income countries. I think it does help to demystify the management of hepatitis B. Initiation of tenofovir no longer dependent on understanding this complex natural history of hepatitis B with the 4 phases of infection. Access to DNA is no longer a barrier to treatment initiation. And promoting point-of-care diagnostics, the rapid diagnostics tests at primary care level, the APRI score for assessing fibrosis, will enable treatment to be initiated at primary care level. But ultimately, successful implementation will require integration, breaking down of silos of healthcare services, but we must have appropriate allocation of domestic resources to actually implement these guidelines. Thank you very much.
Thank you very much, Wendy, for that thorough overview of the guidelines and how they relate to practice in Africa. I will now turn it over to my colleague, Dr. Maria Buti, who's the professor of medicine and consultant of hepatology at the University Hospital Vall-d'Hebron in Spain, and was the leader of the Public Health Committee for the European Association for the Study of Liver as well. And we'll give her perspectives on these guidelines, and again, how they relate to practice settings in Spain and more broadly other high-income settings. Maria, welcome, and please speak slowly to benefit the interpreter who's seeking to help that section of our audience follow along. Thank you.
Thank you. Thank you, John, and all of your team. Good day to everybody. My task today is to speak on the impact of new WHO hepatitis B guidelines in high-income countries. I don't know if it's possible to see my slides. Can you see my slides?
They're coming up, I believe. Yes. Can you?
Okay. According to the World Bank, there are 86 countries classified as high-income economies, and the majority of them are in the Northern Hemisphere. The prevalence of hepatitis B in these countries is lower than in the low-income countries, and also these regions have specific guidelines for treatment of hepatitis B. American guidelines, European guidelines, Asian Pacific guidelines. It's important to realize that high-income countries are very heterogeneous in terms of models of care. Some of them have universal healthcare services, and others are based in insurance systems. Reimbursement mechanisms are different, and also clinical pathways and access to drugs are not uniform. And I would like to highlight that in high-income countries, there is an increased number of migrants. Globally, an estimated of 200 81 million people living outside their country. And if you look at my region, at Europe, it's approximately 36% of the global international migrant population. And this population, it's usually more affected with hepatitis B than the local population. So migrants usually have more difficulties to access and to integrate into the healthcare systems of the host countries. They have language and cultural barriers, stigma, and all of these translate in a higher risk of negative health outcomes. And I think for these underserved and marginalized communities, the WHO guidelines are particularly useful in high-income countries. Wendy has shown the gaps in testing and treatment. This happened in all regions. Even in European region, the rate of testing, it's relatively low, 9%, and those on treatment, only 8%. So clearly, high-income countries needs also to scale up testing and treatment if we like to reach the WHO goals. And this means a radical simplification of care and expansion of treatment criteria. And I think this is the goal of these new guidelines. Let's look at the challenges in the European region. And this is a nice review with Erika Dufel from European CDC that will look at what we need to achieve hepatitis B elimination and the challenges. And still, some European regions have a high burden of hepatitis B virus infection. Viral hepatitis deaths greatly exceed those attributed to HIV or tuberculosis, and there is, as I mentioned before, a considerable variation across different countries and across different populations, particularly in migrant populations. Diagnosis, it's still low. We have a high proportion of cases remains undiagnosed. Hepatitis B vaccine as well as drugs are available, but still suboptimal coverage in many countries, and also suboptimal coverage in hepatitis B vaccination. And this is related particularly because in some countries, it's not included in the national health care system testing for hepatitis B, and also because we cannot access to screening and treatment at the community level. That for me, it's critical in high-income countries to provide all of these services at the community level, particularly for vulnerable populations. So I think we have discussed previously the 5 key points of the new guidelines. And the most important probably is related to treatment, to increase treatment. And some of these criteria can apply very well in high-income countries to treat at the community level. And these are significant fibrosis or cirrhosis evaluated by non-invasive markers, APRI, and transient elastography. At the community level, transient elastography is not available for everybody, so APRI, it's very, very useful. A different point of care weight of testing HBV DNA, and a new recommendation that it's aligned with the growing epidemic of fatty liver disease that is the presence of any of the following co-infection, family history of liver cancer, immunosuppression, comorbidities, and extrahepatic manifestations. It's a different way to view hepatitis B in a more integrated way than only hepatitis B alone. So point of care testing, very useful in high-income countries to detect viral hepatitis at the community for screening, and also testing for viremia to select patients in a different ways with the gene expert, but also with dry blood samples. So this type of assays are an alternative to initiate treatment and also to monitor treatment response. Reflex testing, also a way to simplify and to start quickly treatment. It clearly allows for a reduction in the number of visits and promoting linkage to care and treatment. And this is particularly useful for populations that usually don't are attending the classical healthcare systems. Non-invasive methods, I mentioned before that not high-income countries have access to FibroScan. There are some small hospitals and also at the community that even having portable FibroScans, we cannot access. So having these non-invasive markers to establish the presence of significant fibrosis and cirrhosis, and these lower cutoffs are very useful to start treatment, and this can be performed outside the hospital setting, big advance to increase the number of patients that can be treated. This is an example of a study that we are now doing in Barcelona at the community level, applying all of this, and with a rapid testing, with confirmatory testing, we can treat patients, treat and vaccinate those without infection at the community level. And this is particularly important for migrants. Regarding treatment, usually the majority of high-income countries have access to treatment to all of these drugs. Usually it's not an issue, but the issue is, and these are recent data showing that some of these drugs needs to be prescribed at the hospital level, not at the community level. I think these new guidelines promotes treatment at the community, and this is useful not only for the patients, also for our policy makers to change the approach of treatment for hepatitis B. I would like to finish with mother-to-child transmission, that it seems that it doesn't occur in Europe, but if you look here, mother-to-child transmission is the main transmission category for hepatitis B, despite regardless having access to hepatitis B vaccine. In some European countries, the coverage with the 3 doses of hepatitis B vaccine is suboptimal. For this reason, this new conditional recommendation to use antiviral prophylaxis for all HBs antigen positive pregnant mothers without the need to perform viremia and e-antigen status will be useful to try to reduce in this suboptimal coverage of hepatitis B vaccination to reduce transmission of hepatitis B. And finally, Delta, the most rapid and progressive viral hepatitis. usually is underdiagnosed. And I would like to share with you data from my center on testing for Delta. Testing for Delta, it's very low. It's approximately 10–11% among those HBs antigen positive are testing for Delta globally at the hospital and at the community. And we started 3 years ago with reflex testing for Delta. Reflex testing for Delta increased the number of people tested for Delta. And also for me, what is really important, we increased the number of patients diagnosed with chronic hepatitis Delta, and more than half of patients with Delta didn't have any risk factors, showing that testing based on risk factors is not the best way to go. And reflex testing allows to identify a higher number of patients with hepatitis Delta. In summary, the WHO 2024 hepatitis B guidelines are an opportunity to transform care, even in high-income countries. And as Wendy mentioned, these guidelines are addressed primarily to physicians, not to liver disease specialists, to physicians, primary care physicians, policymakers, and I think we need always the involvement of policymakers to change the approach to hepatitis B. Clearly, the priority areas identified in these guidelines are key areas, and I think even high-income countries need to support these guidelines. Thank you very much for the invitation.
Thank you, Maria. Excellent overview, touching on a number of key points and how they can apply to special populations such as migrants, which in many countries, including the United States, they have the highest prevalence of hepatitis B. And it's really an important community to reach. So thank you very much, for that overview. We'll get back to you with some questions here in a moment. Let me turn it over. If we can have the slides, we're going to go into the panel discussion. We're going to hear from Dr. Ajit Bandoria, who is with the India Institute of Medical Sciences. I just saw Ajit at a recent India Hepatitis Summit, and the meta-analysis to estimate the proportion of persons treated with the previous recommendations was also some of his work on this topic area. But Ajit, welcome to our panel discussion, and so please share your perspectives to get our panel discussion going with the Q&A to follow.
Thank you so much, John, and good evening, everyone. It's 9 p.m. here in India. So I'm deeply grateful to John and Lindsay for providing me this opportunity to contribute in this crucial webinar on the implementation of WHO hepatitis B guidelines and to share India's perspective. So at this point of time, I would also like to mention that I was also the part of the guideline development group member, and Wendy was the chair of that group. And we tried to make the guidelines more, as mentioned by Maria also, it's more for physicians, more for primary care physicians, more for public health approach. So, treating maximum people to get, both incidence and mortality down in future, which are our elimination targets. So first question is, are we, National Viral Hepatitis Control Program in India have adopted or are willing to adopt these new guidelines in India? So answer is no. Right now we are trying to, stabilize the existing operation guidelines in the country. And maybe in future, we'll definitely try to, adopt these guidelines and expand the treatment eligibility. So we are sticking to the old WHO guidelines, and for those who do not know about the National Viral Hepatitis Control Program, it is a 100% domestically funded program in the country, which was launched 6 years back in 2018 on 28th of July 2018. That was the World Hepatitis Day. And this program commits free screening, free testing, and free treatment for all Indian citizens. And the national program is currently facing multiple implementation challenges since last 6 years, and COVID also, gave us a fall for 2 years. And I'd like to mention that these challenges, they are more for hepatitis B than for hepatitis C because of these complex guidelines which we are following. And so I'll try to enumerate few of the challenges and few of the opportunities for hepatitis B in India. So first is how to scale up the testing and screening for hepatitis B to reach our elimination targets. So according to WHO's global hepatitis report, we know that burden of hepatitis B in India is around 30 million out of 61 million in Southeast Asia region. And this is around 12% of the global infection. Diagnosis coverage is only 2.4%, and we are targeting 80%. So currently, I think it's looking far difficult to achieve that target by 2030, but definitely we have to move ahead to increase this percentage as much as possible by 2030. So currently, National Viral Hepatitis Control Program in the country, they are procuring and they are distributing hepatitis B rapid diagnostic kits. And this National Center for Disease Control is the nodal agency for the implementation of this program, and based in New Delhi, and they are the top administrator who are taking care of this program. Second challenge is, or I'll say the challenge for this scaling up of testing is mainly underutilization of these kits. So they are procuring and they are distributing without, capacity building of the medical officers. So they are not comfortable, they are not oriented whom to test. So they are mainly, if I have visited few of the primary health centers, and they are testing mainly for ANC cases, pregnant women at primary care level. In the hospitals, in the facilities, blood donors, if a person is going for surgery, they are being tested. Otherwise, these kits are not utilized and even getting expired at few centers. So data capturing is also poor. So we can't find out the hotspots in the community so that we can go and do active screening. There is very little community screening efforts for individuals, and they are mainly done by either some organizations who are self-motivated, some individuals who are proactively working on hepatitis, and by some NGOs. Otherwise, community screening is very nil, I'll say almost zero. We are just doing passive screening of hepatitis B. The positive thing for scaling up is that National AIDS Control Organization, who is doing a lot of good work for HIV, they have included hepatitis C screening along with HIV screening with their bio-behavioral survey, which they do at a mass level. And also inclusion of this hepatitis B and hepatitis C in our National Family Health Survey, which is a huge survey done all over the country. So these two are the promising steps to increase the scaling up of testing. After testing, the second challenge is hepatitis B virus DNA, so which is not uniformly available in the country. So National Viral Hepatitis Control Program, they are providing funds to states, and now the states are given the responsibility to find out their own methods to test for hepatitis B virus DNA in their respective states. Like if I talk about my state in Uttarakhand, so we are running on a public-private partnership mode, and we have identified one private lab who's doing all the diagnostics for all diseases in the state, and they submit the bills and they submit the invoices to the state government, and then they pay. So if I'm a physician sitting at a primary health center level, I'll write hepatitis B virus DNA testing required. The blood will be collected by one of the person, lab technician, and then I'll get the report. So it's quite simple in Uttarakhand, but it's different in all different states. So that should be uniform throughout the country. Third challenge is, again, as we are adopting the old guidelines, the treatment eligibility assessment. So we are doing fibrosis assessment, APRI, DNA, hepatitis B, E antigen still plays a crucial role in the treatment algorithm. We are assessing for ALT also. So the primary care physicians, they are finding it difficult to do this treatment eligibility assessment. So what they are doing, they are just referring the patient to a higher center for treatment of hepatitis B. And things are different for hepatitis C, but for hepatitis B, it's same. Regarding drugs, everything is provided free, procured. Tenofovir, TDF, and Entecavir is procured and distributed by the nodal agency to all states. But same problem with the drugs also, underutilized, sometimes expired also, and medical officer, they are not comfortable in treating because of this treatment eligibility assessment criteria. Then comes the fifth challenge, which is retention to care. So this is for both those who are treatment eligible on treatment, and also for those who are not treatment eligible, and we want them to come for regular follow-up. So we have done one systematic review and meta-analysis that was a WHO commission with the University of Liverpool and University of Howard. And the results was that even in the hospital-based specialist care settings, the retention of care for those who are on treatment was only 50%. And it was only 35% for those who are on follow-up without treatment. So that's also a huge challenge for keeping the patient in care after they are diagnosed and they're put on long-term treatment or not put on long-term treatment and advised to come for follow-up. Sixth challenge is prevention of mother-to-child transmission. Hepatitis B birth dose plays a very important role, and the coverage is promising, showing increasing trends, but still it is stuck at around 63%. And we want to achieve the elimination target and increase the hepatitis B birth dose in the coming future. ANC screening is universal. Every pregnant woman is getting tested for hepatitis B surface antigen. Treatment eligibility is again the older criteria. If the hepatitis B virus DNA is more than 200,000, then we initiate treatment. Otherwise no treatment. And coverage for hepatitis B 3 doses is very good. It is more than 90%. So that's good. Otherwise, hepatitis B birth dose is the biggest challenge. Then comes the importance of private partners in the country. 50% of our community is still going to these private partners. So they are not pooled in the national program. So we are not getting the complete data. Those who are treated in private sectors, we don't have that data from the private sector. So I think program should find out how to pool them in. In the Indian Hepatitis Summit, a few of the states, they have shared that they have made hepatitis B a notifiable disease. So when you make a disease a notifiable disease, then even a private sector, they have to notify it to the government. So I think that's a good idea. It should be notifiable throughout the country if we don't want to miss out any hepatitis B case if treated in private sector. Then the challenge is data capturing. So I'm really thankful to Clinton Health Access Initiatives. They've developed a great, robust data collection platform for us, which also has an interactive dashboard. But the problem is there is no dedicated data entry operators. So data entry is either not done or done, then it is mostly incomplete or inconsistent. And it is not sufficient to document the cascade of care which we need for hepatitis B and for hepatitis C also. Then stigma and discrimination is still there in the country, and people are suffering. They're not coming for screening. So community mobilization is very important if you want to mobilize people for hepatitis B care. So I think we have to think about how to reduce this social stigma and discrimination also in the country. Last but not the least is operational difficulties, implementation difficulties, which the program is facing throughout the level of cascade of care. So I think from last 6 years we have this program. So I think it's a fertile ground in the country to do operational research, identifying challenges, finding solutions, strategies, and then testing these solution strategies using either pre-post experimental design or a quasi-experimental. I mean to say some operational research design which can help us to generate evidence and for specific intervention which can improve the testing, which can improve the testing uptake. We are talking about reflex testing. We are talking about multiple strategies, but I think these need to be tested in ground in pragmatic approach so that we can have some data for the country. And I really appreciate the core HBV initiative, which is a Center for Operational Research initiative by the Coalition of Global Hepatitis Elimination to promote and support operational research. So in India, as mentioned by John, I am based at All India Institute of Medical Sciences. So we have 20 functional All India Institute of Medical Sciences in the country, and they come in effect to reduce the regional imbalance in the country. So I can coordinate with all these aims, and we can plan and execute multiple operational research in India, as we are struggling to implement this National Viral Hepatitis Control Program, which is the largest 100% domestically funded national program. And I think it's a very promising program in the country. And I really hope that it functions, it do for the betterment of the people, as we are doing for HIV, malaria, and tuberculosis in the country. So thank you, everyone. And I'll be happy to take questions.
Thank you very much. I will get some questions. You raise a number of issues. I know Maria has to leave here in about 5 minutes for another meeting, but Maria, just wanted to, first question popped in my mind was, how is does Spain have national treatment guidelines? Number one, do the WHO recommendations serve to influence those? And I know, you're involved in EASL, and I just ask you to give a status of EASL's updating their guidelines, perhaps with the WHO guidelines as a baseline of information. Thank you.
Yeah, thank you for the question. Giselle is updating the hepatitis B guidelines, and I think they are going to launch the guidelines at the next EASL meeting in Amsterdam. The new guidelines approach will be increase the number of patients that can be treated. So it will be less restrictive, in my understanding, for starting are still under the final process of development. But I think it's really important to know that the majority of guidelines for associations working in liver diseases are more focused on a pathologist, on physicians, experts, than in policy makers. And for this reason, for me, are extremely important, the WHO guidelines, because they push policy makers for screening, for treatment, and at the end for hepatitis B elimination.
Thank you. And we're going to turn it over here to Cal in a moment, but you raised a number of issues that are that need to be overcome to expand access, but you brought up several times how your national treatment guidelines are still based on the previous WHO guidelines. So is there a process underway to update the guidelines in India, or is that still an activity that needs to get started?
John, I think as much as I understand, there is no such discussion going on. I mean, in the coming, I'll say a few months, or maybe this year, we'll not be able to get such kind of any good news that it's updating. So we are really hopeful, and there are many people who are advocating that we should expand treatment and we should adopt WHO guidelines, or at least try to go for some expansion in the treatment eligibility. But still, there is no response from the government, no steering committee meetings, no technical working group meeting. I'm the part of it. So we have not met, I think, from last 2-3 years. So this is really not clear to us whether there is any plan from the government to update the guidelines.
Yeah. All right. Thank you. We can get back to that. Now let me turn it over to my colleague, Dr. Calvin Pan, who's at the New York University School of Medicine in the United States, and has done clinical research regarding hepatitis B in the U.S. and in China, and look forward to his perspectives on expanding access to hepatitis B. Cal, over to you.
Thank you, John. Thank you for inviting me. So for the time interest, I just try to emphasize a few points that what we learned from WHO as American AASLD under the way of developing a new guideline. And we noticed that the WHO guideline writing group take a different approach, is the public health effect, considering the easy implementation of taking care of hepatitis B patients. But like Dr. Putu just mentioned, the European guideline and the American Association guideline would be a lot more leaning forward to the individualized care, which you could have the luxury of utilize the other good resource, including DNA testing, including diagnostic tool for severe fibrosis. So my point is, if you look back for the guideline development, the AASLD will stick with the restrict graded evidence-based guideline, and European Association guideline, now the new version, would towards the expert consensus. They're all evidence-based, but it would take a little bit difference in terms of how to interpret the evidence and how to reach the final decision. And the public health approach like WHO could overtreat some patient, but it will benefit the implementation and also reduce, significantly reduce the mortality and liver cancer. So bottom line is, would AASLD EASL guideline would be similar to WHO? No, because the different settings, different practice resource, and also the guideline development process is different. But I think back to 2022, three associations did have a conversation of how to harmonize those guidelines. In my personal view, something we should do it together. For example, the definition of a disease phase, and those things, there's not that much leeway to interpret it differently. But treatment approach, it could be different. However, what we learned from WHO guideline in America is I have noticed the community start to implement some of the treatment criteria. For example, in Asian community, patients have no resource, no insurance coverage, or undocumented. They start to treat those patients without testing, right? So based on the loose criteria. And AASLD during the developing of new guideline actually could take a more close look on the public health effect. When they assemble the evidence, there is a process you may all familiar with, is the evidence to decision framework. During that process, we have to consider the implementation element of any recommendation and also the public health effect, cost effectiveness. So that WHO, whatever their analysis actually have been shared with AASLD, and the group have looked into it. Of course, you know, the guideline is still in the development. I cannot disclose anything, but the process have started and try to take more close look on the implementation. And AASLD guideline committee also involved patient advocacy group. They have a representative in the group. So those things actually would put a positive impact in the AASLD guideline development. Besides the guideline and implementation, I think Dr. Badoria actually mentioned many challenges during the implementation. I work with Asian countries a lot. I also noticed those challenges, but two things I want to express my concern is there are so many challenges, but you can only do one or two things at a time. If you want to have used limited resource to solve the problem, I think two things I pay attention to. For those audience in front of the camera, you probably can look into your local setting and try to advocate two things, in my opinion. Number one is you have a role in influence policymaking. Focus on screening and linkage to care first. Just like Dr. Ward just presented at the very beginning, if you look at the global diagnostic numbers and treatment numbers, you have 10% patients diagnosed with hepatitis B, only 2% treated. So even all the guidelines now sit down together, we agree with the most liberal criteria to treat, just like Chinese guideline, they treat everybody. So you probably can improve 50% of the untreated patients, right? That 8% not treated, and you increase 4%. Then you got 6% gain. But look at that 90% hasn't been diagnostic, evaluated. Those patients, you're actually fishing on the wrong side of the boat. So this is my first key point that I want to mention is no matter how hard the guy are working on expanding the treatment indication, it's not as a good fact that you can motivate the local resource and policymakers and start massive screening and identify those patients first. The second thing is the mother-to-child transmission is still contribute over 1 million new infection every year. And if you look at the dynamic of the disease globally, those patients have been infected. You cannot change that much except by providing effective treatment. But if you prevent a new infection, and the elimination goal would be easily to get achieved. So for mother-to-child transmission, even the newest guideline, WHO said that you can treat any surface antigen positive mothers without testing HBV DNA. My point is you need to treat them earlier. Whenever you see them, treat them, because if you look at the global burst dose coverage for vaccine, don't mention about HB, in a lower middle income country, it's very minimal. There is rarely you can find a country get a burst dose. So if you still stick with the so-called huge evidence-based 200,000 IU third trimester treatment, that's not the reality. You're going to get a lot of infection. So the reality is treat everybody when they see them, forget about the HBV DNA, and just treat them. That way you can reduce the viral below 20,000. More likely the vaccine will work, even not the burst dose. But even at 2,000, preferably you should give a burst dose. But given there is no burst dose, then if you want to achieve 20,000, the threshold, you must treat mother at least 6 months. We just have a new publication with our HBsAg study. So this is something important message that I want to bring up to the group. You treat every mothers when you see them, because likelihood in the lower income country, you don't have burst dose of vaccine. Don't even think about HBsAg. I hope those would help you to think, rethink the whole thing of elimination.
No, thank you very much, Cal. I know we're running a little short on time, but I know you're very involved in China, doing a variety of different studies there. And I know China, liver associations have come out with national guidelines for hepatitis B treatment that are a little bit different than the WHO guidelines. Can you briefly describe those, please, just to help people understand that they're available?
Yeah, the guideline actually have an English version, published in Clinical and Translational Hepatology. Mainly 3 things. They expand the treatment criteria to any Hep B surface antigen person who are age under, age over equal 30 or greater than 30, with any detectable HBV DNA, regardless HBV DNA level and ALT level. Of course, cirrhotic, everybody would agree to treat with that, but even non-cirrhotic. That criteria actually can give you the indication to treat any adolescents. You just don't need anything. So that's the most liberal criteria by far, by any national level of guidelines. And the second thing is I did involve in their guideline development and also a new pediatric guideline, and suggest that you should test the influenza earlier, not waiting for 1 year, but preferably 6 months or even earlier, because the early treatment of pediatric population, there are data suggests that they have somewhere between 30% to 50% functional cure rate. If you treat them before age 2, that decrease after age 6. So those are the new developments, I think, because given the high prevalence of hepatitis B in China, when they move very aggressively, taking a public health approach. Is it a great evidence support? Probably not, but it will benefit. It will reduce the outcome of cancer and cirrhosis.
Thank you so much. You raised an important point about the really key intervention of screening, expanding access to screening, and then improving access to care. And Ajit, you mentioned that as well. And there's been a lot of comments in the chat regarding point of care testing for HBsAg and the fact that that's not available in the United States yet. Just wanted to see if of you and Wendy wanted to comment on how that's being used in your countries, and then finish up if Cal has some perspectives on point of care testing for HBsAg. Over to you, Ajit.
Okay, so John, like we have rapid diagnostic kits available, and they are being utilized in the clinics. So mainly the patients who are coming to primary health centers, community health centers, district hospitals, or other hospitals, they are being tested by these kits. And if I talk about my center, so we are doing the detailed analysis of all those who are coming positive, and we have identified 2 or 3 hotspots in Uttarakhand state, and we go and then we do active screening also using these kits. Other than using these kits in the community, second important is family screening. In hepatitis B patients, family screening is also very important. So whenever we get a person who is hepatitis B positive, we screen the parents, siblings, wife, spouse, and the children. So all they are screened not only for hepatitis B surface antigen, but also for anti-HBc core, and if it is positive, then we go for hepatitis B DNA also. Sometimes we get occult hepatitis B also. So point of care testing is available, and we are trying to use it. Mainly it is used in the facility. Some institutes, they are going out and doing some community screening camps also, but family screening is also very much promoted, but it's also institutional.
Thank you so much. Wendy, is point of care HBsAg testing available in South Africa?
Point of care is available. It's still very limited, but what they are looking in terms of actually updating our guidelines towards the WHO is actually implementing the rapid diagnostic tests. And our approach really is, obviously population screening is expensive, but using the pregnant woman as the index to screen, then recommend screening the partners, as I just said, the family, and really utilizing that as a sort of more cost-effective way of actually screening and diagnosing and linking to care. And that's been, so far, the uptake has been good.
That's great. I'm glad you both raised that aspect of extending treatment, screening into families, given the high likelihood that other family members will be infected if one family member is HBsAg positive. It's really a very, very key intervention that's underutilized at this moment. It's great to see that's underway in your countries. Do you think there's a role for point of care testing for HBsAg in the US, Cal?
Yeah, you brought up a great question. Let me take one step back. Since we are focused on the middle and lower income country, and China is one of them. And from China, I'll move back to USA and talk about that. So in China, actually, there's a lot of development efforts on the rapid testing. And lately, I got involved in one of the projects is use the CRISPR to detect HBV DNA using RNA, which the paper have been published. You can search for that, and developed by Beijing Capital University, and really driven the cost of close to nothing. It's like 5 RMB is less than $1 US. I think it's no doubt in my mind, it would be easily get adopted in the country to replace HBV DNA and with very good sensitivity and accuracy. Now, since this is a global conference, and including John, yourself, and the others advocacy group, what I would suggest is if we can group everybody together and try to work on a universal pattern or approval across every country, if we can move this campaign as an advocacy group, that will solve a huge problem. There are a lot of very high advanced technique from China or the other countries, but the major barrier is the pattern and the approval of local countries, because those tests actually is very, very low profit, right? There is no financial support to try to go through this complicated licensing process. If our group can work together with the other group to make sure, at least for this, the point of care testing or rapid testing can be easily adopted by every country. If the authority goes to WHO or whatever channel can approve that, I think it will make a huge impact. There is available. So back to the US, the point of care testing definitely is a a great replacement of lower cost testing. And now you know that the insurance premium is skyly high, right? And our Americans suffering from healthcare benefits, not getting enough benefits. So that will control the cost. I do believe that there is a huge role here. But again, the licensure process, nobody would be able to step in with paying a huge cost of licensing.
Yes.
That's my point.
No, you're absolutely right. I know in our own work in Africa, just every African country having their FDA equivalent,
Right.
and the cost of going from one country to the X. And we talked to Africa CDC about having a regional approach, for example, rather than
Absolutely.
a country approach. So that's a very key area. We turn it over to my colleague, Dr. Neil Gupta. In particular, all of the presenters and panelists have raised different issues regarding screening, linkage to treatment, adherence to care and treatment, monitoring outcomes, informing national policy development, and wanted to have Neil touch on some of those gaps and how research can address them. Neil?
Great, thanks, John. And it's a pleasure to be with colleagues today. Very interesting presentations and discussion so far. Next slide, please. As John mentioned, at the Coalition, we've been very interested in learning from these guidelines and really acknowledging the additional pressures that these expanded guidelines, as described by so many of our speakers, will place on already overstretched health systems. I think we've all been following the news recently and realizing that health systems are only going to be further challenged to address infectious diseases, not only Hep B, but HIV, TB, malaria, and others that have been externally funded for so many years. These expanded guidelines will put pressure on low and middle income countries to respond to additional diagnoses and treatment eligibility. Next slide, please. So in that light, next slide again. In that light, I think the WHO guidelines, and as you flip through, you can see that through each chapter of the WHO guidelines, they've offered a research agenda, and many of the guideline leadership here well knows that there are over 54 bullet points on research questions that can be explored or that are recommended to be explored in the upcoming years, but not necessarily a prioritized look at which questions would be most critical to expand service delivery. Next slide. So at the Coalition, we were quite interested in this question, and I think Dr. Ajit brought this up in terms of operationalization and simplification of health system delivery for expanded treatment guidelines. And we assembled a group of researchers, hepatitis B experts and researchers from LMICs throughout 2023 and 2024, brought them together to really think about how we could identify operational research priority areas, key questions for research, how we could describe high priority research studies and start to detail those out, how we can assess existing and needed research capacities in LMICs, and also how we could best engage national policymakers. When this group came together, they identified several key themes. The first is that strong evidence-based models of care delivery are needed for hepatitis B, based on lessons already learned from hepatitis C and HIV care delivery, and that operational research should really take a core philosophy of learning while doing. So not necessarily waiting years and years for research results to inform care delivery, but rather to roll programs out, but to do that in a way where we're actually measuring the impact of new operational methods. Next slide, please. We kicked this group off by conducting a scoping review on evidence gaps for operational research in LMICs for hepatitis B care delivery. And we found only 56 studies that implemented and measured the effect of an intervention. There were major evidence gaps, which I think doesn't surprise anyone here, in terms of screening, assessment, linkage to care, treatment, monitoring, and also cross-cutting issues around healthcare worker training and education, community awareness and engagement. These evidence gaps linked well and coincided with qualitative information from each of these researchers as well as to what they saw as operational research needs in their own countries. Next slide, please. This also complemented a commission study that was done for the Guidelines Committee, looking at care cascade outcomes and doing a systematic literature review on care cascade outcomes globally. You can see here just the size of the circles indicate the number of individuals included in care cascade models. And you can see that in the highest burden areas of sub-Saharan Africa and Asia Pacific region, South Asia, less studies having been done and smaller cohorts having been generated. Next slide, please. So with the group invited by the coalition to join a workshop as well as the scoping reviews and qualitative interviews, we were able to produce a set of priority areas for operational research in hepatitis B to simplify care delivery in LMICs. And we really came down on 4 priority areas. The first was to simplify delivery models to assure decentralized and equitable access to hepatitis B testing and treatment. The second is really around PMTCT. Third was developing and operationalizing technologies, particularly around Hep B diagnosis, treatment and monitoring. And then fourth, thinking about back to the question of who to treat, understanding which persons are at highest risk with a Hep B infection to progress to fibrosis or hepatocellular carcinoma. So a bit of a different lens on research priorities than the WHO guidelines, which were much more comprehensive and systematic in nature. Here, we went through each one of these priority areas in a workshops format. If you can go to the next slide, please. Encourage you all to download our operational research roadmap. But here's just an example of, for example, in priority 1, some key questions that could be answered via operational research to inform decentralized service delivery models. Next slide, please. For example, the first question here, how can hepatitis B testing and treatment be effectively provided by non-specialists at different levels of the healthcare system, particularly thinking about rural facilities manned by non-specialist healthcare workers in rural parts of sub-Saharan Africa being a first priority. Next slide, please. So just illustratively to show you that we do have tables in this roadmap around the design options, study examples, and outcomes of interest to be measured in a standardized and systematic fashion by research studies outlined in the roadmap. Next slide. So you can just advance through these. Again, this is research area number 3 and area number 4. And if we look at these, if we go to the next slide, just in the interest of time, you can advance through this just to show how some of these research priorities map to the WHO guideline research priority areas. So in looking at our research priority area number 1 around decentralized simplified care models, really mapping to some of the simplified service delivery aspects on the left side of this comprehensive research agenda. Our priority area number 2 in the roadmap around PMTCT obviously speaks to the bottom right corner of treatment in adolescents and children, as well as the use of prophylaxis during pregnancy. Our priority area number 3 around the development of innovative testing technologies really speaks to the use of non-invasive tests, point of care Hep B DNA testing, and reflex DNA testing. And then priority area number 4 around monitoring and surveillance for long-term outcomes and determining who to treat. So we found a real nice concordance between the operational research prioritization exercise that we went through for the roadmap with the comprehensive research agenda outlined by the WHO for hepatitis B. And we hope that it can give that the roadmap gives some very practical and actionable tools to guide LMIC researchers, and also can serve as a advocacy and fundraising tool to bring in new and additional funders into the hepatitis B funding ecosystem, which we've already kicked off here as part of a roadmap. This initial work was funded by a philanthropic group called Open Philanthropy here in the US, and has already committed to the phase 1 of operationalizing this research roadmap. So at the UN General Assembly last year, at the Group of Friends for Hepatitis convened by the UN, we announced the launch of Core Hep B, or the coordinating coordinating center for operational research for hepatitis B and LMICs that will be housed at the Coalition for Global Hepatitis Elimination at the Task Force for Global Health. This is a roadmap that describes some of the activities that Core Hep B will be taking on. So not only assembling a portfolio of operational research with investigators from LMICs, but also engaging policymakers early on in respective countries where research is being conducted, so that there can be seamless translation to programs and policy from research outputs. As well as long-term goals of capacity building for research institutions. So welcome you all to visit our operational research roadmap, and we'll be following up with more details about Core Hep B, which will be discussed in greater detail at the upcoming Global Hepatitis Summit in Los Angeles in March of this year. So thank you very much, and with that, I'll pass back over to John.
Thank you very much, Neil. We are launching the Center for Operational Research on Hepatitis B to examine ways to improve access to care and treatment, beginning with screening. I think it's many of the questions and comments in the chat, relate to these different, gaps in that continuum of screening, linkages to care, and then treatment decisions, treatment adherence, and maximizing treatment outcomes. And that's what we're going to be looking at in the operational research that's going to be coordinated by the center. We're not able to get to all the questions, many of the questions today that focus on that, but I see one of the roles for the center is to convene webinars like this, so we can examine different aspects of the continuum of hepatitis B care, beginning with screening, and so look forward to engaging all of you in those discussions as we strengthen the evidence base to help and address them. We're also very committed to building political awareness about the benefits of hepatitis B care and treatment. Look forward to working with you in that regard, including, as was mentioned in the chat, what we can do to improve access to screening, care, and treatment here in the United States. So all of that more to follow on all of those different aspects. Thank you all very much for your participation. I want to thank all our speakers and panelists for an excellent overview of the WHO guidelines and how they are expanding access to care and treatment. And with that, a foundation seeking to address all these other gaps so that people with hepatitis B can receive the care and treatment that they need to benefit their health and help us achieve the goals for hepatitis B elimination. If you have any other comments, please pass them along to me individually, John Ward, jward@taskforce.org, or at our website at globalhep.org, and look forward to continuing to work with all of you toward our shared goal of eliminating hepatitis B as a public health threat around the world. Thank you very much.